amigo, HOA NGUYEN, profesor, por favor. Es un amigo, y no lo digo porque todos sean amigos, sino porque nos ha ayudado a todos los que estamos trabajando en Latinoamérica, en Huntington, y tenemos problemas para poder hacer el diagnóstico genético, y siempre nos falta 5 para el peso. Y HOA siempre está disponible para mandarnos lo que nos hace falta, para mandarnos procedimientos estandarizados, para capacitar. Así que, bueno, eso es lo más importante, pero además de todo eso, voy a leer porque realmente es impresionante. Él es un genetista clínico con formación en oncogenética y por supuesto también con una vasta formación en neurogenética. Él lidera, junto con las clínicas de neurología en Bochum, el centro de Enroll HD que se encuentra en la cabeza del reclutamiento mundial. Un aplauso por eso, el centro. Es el mayor reclutador, no me acuerdo exactamente el número, pero 1049 participantes ha reclutado. Okay. Así que, the winner.
Thank you very much.
Pero además, como supongo que le queda tiempo libre, es investigador, dirige una cátedra, es profesor y realiza investigaciones acerca del efecto de las enfermedades por expansiones de poli-Q y desarrolla modelos animales para ensayar distintas terapias posibles. Así que bueno, mil gracias, Joa, por estar acá y mil gracias por poder contar con vos siempre.
Thank you very much. Mille gracias to Claudia and Nacho and also Roger for inviting me. And it's my pleasure to be here. It's my first time in Colombia, and my father and I, we enjoyed it a lot, especially the people. Yeah, very friendly people, very open, and we had a great time. So I will talk today about more of my clinical work than my research work, and I would like to start with the group that is actually behind our HD center, and this is only part of the group. So this is the people that were, I think, almost a month ago in Bologna at the EHDN meeting. So to point out, especially when we're talking about Enroll HD, it's mainly Carsten Saft and his team and neurologists that are enrolling the patients, while I'm and my team are on the preclinical side and on the diagnostic side. So our center in Bochum has been established in 1993, so almost 30 years ago. So we were probably the first Huntington's disease center that was established in Bochum, and we have several pillars that we actually encompass in our center. So one is the human genetics part, which I will talk about today. I'm the head of the department, as you have heard, but I see actually all the HD patients that come into genetics for predictive testing and for confirmation of the diagnosis. And I see about 2 HD patients every week for predictive testing. About half of them actually do the test in the end. And we have about 150 to 200 tests per year on HD in general. Carsten Saft is the outpatient clinics in neurology. He sees about 300 patients per year. And as you already mentioned, we have more than 1,000 patients in Enroll HD enrolled in Bochum. But there are also other parts of the center. So we have preclinical research. We have generated HD rat models, but also done some molecular pathomechanism studies. And we are one of the few centers, probably the only center in Germany that has a HD clinical ward, so that we actually see patients in the clinics and that they can stay over days, weeks to be diagnosed and treated. It's part of the Center of Rare Diseases, and the state of North Rhine-Westphalia has just recently given 5 million euros to the Center for Rare Diseases to actually build up on these clinical care for HD and other rare diseases. And we have a cooperation with the psychiatry, with the children's hospitals, where we see about 8 juvenile HD patients per year. So it's not that many, but in Europe, in general, the HD cases with juvenile onset are rare, much rarer than I think probably here in this area. In neuroanatomy, we work together with Elisabeth Petrasz-Pavic, who has a range of HD brains that we can actually also investigate. So almost 30 years ago was the gene discovered, and we all know that Latin America has been the crucial part of that to how the gene was discovered. And that actually was also the year the HD Center in Bochum was founded, and especially after the mutation was discovered. So we already heard that, and I will go quickly through it, so we will stay in the 20 to 30 minutes that I have. So we have the expansion of the CG repeat in exon 1 of the Huntington gene, which translates to a polyglutamine stretch, which is then, if it's expanded more than 36, and in total with 100% penetrance when it's more than 40. So I will quickly go through how we do the genetic test, but I would also like to emphasize that currently we are having Ukrainian students in the lab who are actually coming to the lab to learn how to do molecular genetics work, but also clinical genetics. And what they are doing is that they are filming videos on how we're doing diagnostics. And these videos will be edited together with us and others, but we will be able to provide you with these videos as well. So if you are interested in how we're doing our genetic tests step by step, just send me an email and we will be able to provide you with the videos in a couple of weeks. So the idea is that you get a blood sample for genetic tests, you do a DNA extraction. There are kits nowadays for that, or you can do it automatically if you have a large number of samples. And in the end, we get the DNA extracted, which can be then used for genetic testing. So there are different SOPs, standard operation procedures, how you do that. In our lab is that we have always an A and a B sample when we take the blood, and every sample is at least run twice. So actually, for predictive testing, we have at least 4 times the test to be quite sure that we give the right diagnosis to the patients. So in general, you get the gene of interest. In our case, it would be the Huntington gene with the CAG repeat expansion, which we amplify by PCR. We use fluorescent labeled primers. With that, these fluorescent fragments are amplified multiple gene copies, and that will be then run in a capillary electrophoresis system. So this is the system that we use in the lab. Basically, is it like a capillary system where you actually inject the electrokinetically the DNA fragments into capillaries, and by high voltage, the different fragment sizes are separated according to the size. And since it's fluorescently labeled, a camera, a laser, can actually detect the different fragments, the different sizes. And how does it look like? So you will have different peaks of which represent the different fragment sizes. And for example, here, oops, now I'm also getting this. You see the red line, everything above that has a size that is that corresponds to a CAG size bigger than 36. That's our threshold. And as you also can see, you don't have one peak, one length, but you have several peaks. So that's why our diagnosis or our report always says ±1 or ±2. If we are not, because we cannot be really sure with the gold standard at the moment how big our CAG size is. It's an estimation according to the fragment length. And basically, you can use a ruler, yeah, and then calculate the size. And according to that size, we have then a diagnosis. For example, here you have 2 alleles. One here is the 17, and this one here with the highest peak would be 52, and then we give us in the report 52 ± 1 CAG as our genetic test result. So I would like to explain to you how we do that and how we counsel patients with a specific case that I saw last year or 2 years ago about that, and that is that this patient at the age of 56 came for genetic counseling for predictive testing because in the family her brother died of Huntington's disease and her father and her aunt died of Huntington's disease. So in a center like ours where we have clinical data and also reports going back 30 years, I was able to take out the clinical reports from the family members. And so I will talk about that later, but in the family it was already predictive tested. The nephew didn't have the mutation, and the sister at the age of 48 doesn't have the mutation either. And now she comes at the age of 56 and asks for predictive testing. So how are the guidelines to do predictive testing? And there have been guidelines established already in 1994 after the mutation was found. There were already guidelines published, and these have been updated in 10 years ago. So the guidelines for predictive testing, and that we actually obey by, is that we have to make sure that the decision to take the test is the sole choice of the person concerned. So there should be no request from a family member or from a third party. The test should also be performed with a multidisciplinary team. So besides us as a clinical geneticist, genetic counselor, we also involve a psychologist or a psychiatrist to talk to these patients at least once. And we also offer them a visit to the neurologist, to Professor Saft, to Carsten Saft actually. So within this team, we make sure that they can talk to different specialties and get all the information that they want. It is recommended that the minimum age of testing is 18 years, so we usually don't test kids as predictive testing. And all laboratories are expected to comply to the OECD guidelines for the quality assurance in molecular testing. And this is very important, as we have seen with different studies that we have a discrepancy in CHG sizing in different labs. And if you don't follow like schemes, quality assessment schemes like the European quality management system, it could be that you go into discrepancy in your CHG sizing. So going back to that family, so yes, I forgot one slide. Yeah, so we usually have several sessions with the patients before they actually disclose the results. So the first consultation is just for information of the patient. Yeah, it's a pre-test genetic counseling which includes legal, ethical aspects as well as psychosocial aspects. Family history are taken. We mention all the possible test outcomes, including intermediate and reduced penetrance results, because that could also happen. And usually we require them to have one or more counseling sessions with a psychologist or psychiatrist. We outline also the whole procedure that we would like to have during disclosure of the results, that they come with a friend, partner, or a family member. And so we usually have a consideration period so that they have the possibility to withdraw from that testing. And that period is supposed to be at least 4 weeks. So from all the patients that I see that come for predictive testing, they already have quite made their mind, yeah? But still about 50% don't come back after that first session. Yes, because after all the information that we gave them, yeah, for example, we don't have a cure at the moment, we don't have any treatment that will postpone the disease. So a lot of them, about half of them decide not to go further. Then the blood sampling takes place, and then after the blood sampling, we say about 2 to 4 weeks is what we need for the genetic test results to be completed, because we run several rounds. And then we disclose the test results. The test results come, because I usually do all the genetic counseling and consultations with the patients in a closed envelope. So I don't know the results until the patients come. Yeah, so that is also protect us from a counseling bias or somehow revealing the results to the patients while they try to reach me on the phone, or then sometimes they try to call you, yeah, and find out if I have a good results. I would actually recommend that they come in sooner. Yeah? So that's to protect myself and also the patients from this kind of bias. We always say it's a closed envelope that I will keep until they come. And I have actually a folder full of closed envelopes that haven't been taken so far. Yeah, so that always a possibility for them to withdraw from the blood sampling until the results are disclosed. And then the results are disclosed with a companion or psychologist, and then we also offer them post-test counseling. Yeah? So do they need another session with a psychologist? Should we call them in a week or in 2 weeks, how they are doing? So we actually lay out the possibilities after the test results. So going back to that patient that I saw at the age of 56, her brother had an onset of the disease at the age of 30 and died with 40, and he had a 44 CG size. And when I looked into the old files from the father. He had an onset at the age of 40 and died with 63 and had 37 CG. So it's unusual for him actually to have such an early age of onset with 37 CG and an increase by 7. It could happen, yeah, but with paternal transmission, we have anticipation more often than maternal transmission. But she was now 56 without any symptoms. So the chance of her having the disease might be lower than 50%, yeah, just by family history. But this case was more complicated, yeah, because with 44, yeah, you usually don't have an age of onset at 30. Just to remind you of the CG sizing and the age of onset. And 37, usually it's a reduced penetrance. But this patient actually, yeah, so again, 40, 100% penetrance, 36 to 39. The father had 37, would be a reduced penetrance usually. And 27 to 25 would be intermediate allele, a premutation, normally no symptoms. But this patient, it is in German, this is an old report. She went to an indirect test in 1989 in Göttingen. Yeah, so before the gene mutation was discovered, they did an indirect test, and they gave her a chance of 96.1% to be a mutation carrier. Why is that, right? So this is and that's why she didn't dare to come to genetic counseling after that. Yeah, but they actually told her when this gene was found to come back to do a direct test, but she never wanted to do that because she already had a 96%. Her brother was given a 94%, and he died before she was even diagnosed, or she didn't have any symptoms. So 96% of probability of having inherited a mutant allele from the affected father. So was there a mistake at that time, or what was the reason? So we did the direct test after consultation, and she had 34 CAG size. So it is actually the allele, the mutant allele that was inherited from the father, but we have a contraction from 37 to 34 with her, and from her father to her brother was an expansion to 44. This is unusual, yeah? So that usually you don't see that, and that's why I always tell them, you cannot expect, we cannot actually predict what comes out. And the problem is, and this is one of the work that we did with Michael, who just came in, good, that we looked at loss of interruption in these reduced penetrance alleles. And we looked actually at the father who had 37, and he has a lot of a CAG interruption. And that led to this more instability, not a somatic instability, but a germline instability within this family. Yeah? And we also looked at the brother, and he has also loss of CAA interruption. So clearly, because of this loss of CAA interruption, we have a high instability within transmission of the family. Yeah, so just to remind you, and Vanessa has talked about this morning already, the loss of interruption. Yeah, usually when you do the diagnostic, you would have maybe a predicted onset that is much later. If you correct it by the loss of interruption +2, you would have an earlier onset, the blue line. But actually, we see even earlier onset, but much earlier onset if we look at the actual age of onset of these patients. So this would explain why the father with 37 had this symptomatic already at the age of 40, and why the brother with 44 had an age of onset of 30 and died with 40. Yeah. So, but what does it mean to this woman, that patient that I saw with 34 CHG? Usually I would say not being affected, no risk of developing the symptoms. And this would be the standard of care in our diagnostics and also in the clinical genetics. Would I now tell her of the loss of interruption, which we only did in a research study? We know about it later, but not when we disclose the results to her. And this is one of the problems that we have now to deal with, and we will look at this in a study, how to deal with that, yeah, and look at more families and what are the the chances, the risk. The next would be then, of course, these two, her children, because she decided after getting the 96% indirect test of risk to have children nonetheless. Yeah? And she might have been lucky, and these two kids actually were then at the consultation shortly after her and wanted to do a predictive test as well. And were hoping, because I gave her quite good results with 34, that it would have similar results. And what would happen? The son, we could exclude him, so he didn't have the mutation at all, but the daughter has 34. So it remains stable from the maternal transmission, and it is probably what we would have expected, but we cannot be sure with the loss of interruption how stable that would be. Yeah. So with her, also, yeah, not sure what to tell her, how her chances are of developing Huntington's disease, but it should be lower, and if she's going to develop symptoms, it might be much later than most of the people. So when we go back to the publication by Michael's group, yeah, for intermediate alleles with 34, yeah, only we would have an increased risk for males for the next generation. But how that actually applies for females with a loss of repeat interruption, we don't know yet. And this would be one of the studies that we should do. And there is always new things to learn and to study, even though a genetic test like this has been here around for more than 30 years. Good. So when we talk to the daughter now at the age of 24, family planning, what are her options? Yeah, with 34, could be that taking the risk of 50% chance to give the intermediate allele to her offspring, or maybe even longer. We don't know. Decision against own children. Some of our patients decide to not have children after getting the diagnosis of being HD mutation carriers. Adoption would be another option. Sperm or oocyte donation, yeah, in this case, yeah, because the daughter is affected or has the premutation, sperm donation would be possible legally in Germany. Oocyte donation would not be possible in Germany. Yeah, so it depends also on the country which options you have. Similar things apply to prenatal diagnostics. Yeah, so with the new legal genetic diagnostics law that came in in place in Germany in 2010, there was a passage that says we are not allowed to do prenatal testing in late manifesting diseases. So one could argue that Huntington's disease, there are juvenile onset of diseases, but with 34, we would not expect her children to have a juvenile onset. So she would not be able to do a prenatal diagnostics in Germany. Other options would be pre-implantation genetic diagnostics, PGD or PID. That would be possible in Germany, and it's a complicated process, but it is possible. So what are the possibilities for prenatal or pre-implantation diagnostics? In general, there are different possibilities. Yeah, so one, the pre-genetics diagnostics, pre-implantation genetics diagnostics is done shortly after conception, yeah, on day 5, for example, of the after conception. You could do prenatal diagnostics with chorionic villus sampling, CVS, or amniocentesis, AC, which actually can be done either 11 weeks after conception or 14 plus weeks after conception. And the chordocentesis is a sampling of the blood, of the umbilical vein blood, usually done after 18 weeks of conception. So how is that done? Yeah, so in general, by ultrasound, you can do a puncture, remove amniotic fluid, and this is then cultured for 2 to 3 weeks until you get enough cells to get enough DNA to do the prenatal test. So usually, if you do an amniocentesis, it's 14 plus 2 to 3 weeks, it would be 16 plus. So it's quite late in the pregnancy. So usually that is not the choice of prenatal diagnostics that is performed if you do prenatal diagnostics, but you would rather do a CVS, choriocentesis, with a via ultrasound, also puncture and taking a biopsy of the placenta. And with that, you have usually enough tissue to get DNA samples that are of high amount that you can actually do the diagnostics test immediately, so that after 1 week after the puncture, you would have your results, 11 plus 1, so around 12 weeks of pregnancy. Another possibility is the choriocentesis, as I said, puncture of the umbilical cord. Usually this is not done because it's quite late, 18 weeks of age and 18 weeks of pregnancy and later. So what are the risks? Yeah, so or comparison in general for the AC, 14 plus 16 weeks, so it's quite late. So usually it's the CVS that is performed. Success rate for CVS is 95%. Sometimes you have to do a repeated puncture. For example, if you have maternal contamination, you cannot exclude that you are investigating the maternal DNA, so that's why you have to repeat it. Miscarriage risk is around 0.5%, so it's quite low. There's other risks which are 1 promille or much smaller, so that can be actually neglected. The other possibility is what a lot of patients nowadays also ask for, is the pre-implantation genetic diagnosis, PGD. So this is actually making sure that you implement the embryo which doesn't have the mutation. Usually it is, what you need for that is a ICSI, so it's an intracytoplasmatic sperm injections. And when the fertilized egg has developed to a specific stage, and nowadays it's not in the 8-cell stadium, but you wait until day 5, you have about 100 cells. You remove about 5 cells to get enough DNA to do the diagnosis. And after that, if the embryo is found to not have the mutation, it's implemented into the uterus. The legal framework is country-specific. Yeah? So for example, in the Netherlands and in Belgium, we have less strict laws than in Germany. In Germany, you would have to submit proposal to an ethical committee that decides individually whether they agree that you can do such a PGD, PID, which takes a while. And in the past, we had also problems with that, depending on the state that you actually submit your proposal. In the more southern state with more Catholic Catholic population, it was a little more difficult than to get approval in North Rhine-Westphalia. But that has changed now with the legal circumstances being in place now. So usually it's always needed that you have an intracytoplasmatic sperm injection, so which also means that you have to give hormone replacement to actually harvest the oocytes. When we look, and this is data from 2016, 2017 in Europe, what was the most common indication for PGD, PID, and you see Huntington's disease is the most common indication that was actually done already in 2016, and this hasn't changed since then. Good. Important is that where we counsel these patients and talk about family planning, that we refer to the lay organizations. While I can tell them the technical, the legal circumstances, usually it's best for the patients to talk to lay persons or persons that have undergone the same procedures already. Yeah, they can actually recommend more directly doctors, centers that they had good experience there, and we have with the German Huntington's Disease Association, a great lay organization that has actually some responsible person just for family planning. Yeah, so that person actually explains her own journey and the experience she had. Yeah, she did PGD. Yeah, Isa, you know her. Yes, she actually had 7 trials until she was successful. Yeah, so. There are different stories to that. Sometimes you are successful after 1 trial, sometimes you have to redo it several times. There's always the youth organization that is often very helpful in this kind of question of family planning. And with that, I would like to thank you, and hopefully I remained, yes, in time.
Mil gracias, Joa. La verdad que hermosa tu charla, increíblemente clara. No sé si tienen muchas preguntas, pero a mí me gustaría más que preguntas decirle, Joa, ¿qué te parece si venimos en un tiempito lógico y nos das acá en Colombia un curso intensivo de diagnóstico genético y todo lo demás?
You have to ask.
Congrats for your talk, excellent talk. But
Thank
I
you.
want to commit to you to come here with me to Colombia, and we can give a course on genetic diagnosis for Huntington's disease and genetic counseling and pre-implantation and prenatal options. What do you think?
Of course, I'm up to it, and we actually started also consultation by video telehealth, so for our patients. So it would be also possible if you need consultation here, and if I can help out, of course I can help you. As I said, the videos on the procedure will be done in the next couple of weeks. I can share them so that you know how we do it, and if you have questions for that. And as always, if you need something, DNA samples or markers, we can send them to you.
Thank you so much. ¿Preguntas para Joa?
I think
Acá. Okay. Mario?
Congratulations, it was a wonderful presentation and so very useful. I'm coming from Peru, and so we are just starting 1 year ago our predictive testing program for Huntington's disease.
Great.
So we are in the process with a lot of issues dealing with many things. So my question specifically is regarding the confidentiality. So what about where at-risk persons complete all the process and you have the result. So do you store the result in the clinical record or not, or is just separately? Because we consider the second option to put it separately and just consider like an overall report of what has been done in terms of genetic counseling rather than the report to protect the participants.
It depends on what the patient wants. So we actually talk to them because some of them would like to have the results sent to their primary care physician, which we don't always agree on that it's the best choice for them, especially if it's predictive testing. Yeah? So our reports only go to the patient themselves. If they request to be sent to someone else, we will do that. Another question is insurance. Yeah? So what to do with that? And when we actually do a diagnostic test, it's paid by the insurance. They know by a code that we did the test, but they don't know the results. And this will be also not disclosed to them. Sometimes, of course, it's difficult if there are private insurance in Germany and other things that you don't want your test results somewhere on record, even if it's not with your primary care physician. So we also offer pseudonymized testing, if that is what they request. But then we cannot actually charge the insurance company, of course. So they have to pay the test out of pocket. But that is usually affordable for most of the patients.
Muchísimas gracias, Joa.
Thank you.